Heathrow Healthcare, the journey began since 1993. We have 30 years of excellence and 300 plus products in portfolio. We have 36 state-of-art manufacturing facilities and presence in 126 plus countries. Heathrow Healthcare has got 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. We are pioneering in quality and innovations, and we have distinction of bringing 4 biosimilar products to market within 5 years of its launch, like darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare will take pride in introducing antivirals, oseltamivir, favipiravir, and remdesivir, for which Heathrow Healthcare received an award of Pharma Excellence in August 2020 for COVID drugs. With this brief introduction, we come to today's webinar. Today's webinar we know is influenza and its prevention. Influenza we know is a potential troubling condition, especially in children. Although there are many papers and documents on use of oseltamivir in influenza, we always like to get our own doctor's insights into the disease and treatment. Today we have got eminent speakers like Dr. Mahendra Patel and Dr. Muralidhar Mahajan. Welcome, sir. Welcome, both of you. Just to mention brief about them. Dr. Mahendra Mahajan is a senior practitioner in practice since for past 30 years, MBBS from GS Medical College and KM Hospital, MD from LTMG Science Hospital, Diploma in Mother and Child Health. He has done certificate courses in pediatric asthma, pediatric neurology, and pediatric intensive care, pediatric nutrition. Has been associated with various IIP and IME activities. He has long been associated with GMA and he was past president of Goregaon Medical Association. He has been secretary of Medico Music Circle and Goregaon Pediatric Forum. Sir is certified diploma holder for interior design. Wow, wonderful, sir. Welcome, sir. Dr. Muralidhar Mahajan is MBBS from GMC, MBBS from GSMC, MD DCH from GMC, DNB National Board of Mahajan, DNB National Board of Examination Delhi, MNAMS Postgraduate Program in Pediatric Nutrition from Delhi University. Sir is consultant Jupiter Multispecialty Thane, Assistant Professor Genetic Division of KM Hospital, presented more than 150 papers at both national and international conference, has delivered more than 200 talks at various CMEs and conference. Sir was organizing secretary at Mahapedicon, MPCon, and KMA Con. Has conducted several webinars which was attended by PG doctors, nurses, and pediatricians on topics like vaccinology, immunology, infectious disease, breastfeeding, nutrition, skin care. Welcome, Dr. Mahendra Patel. Welcome, Dr. Muralidhar Mahajan. And thank you. Sir, handing over the session to you.
Yeah, I'll share my screen this thing.
Yes.
Yeah, visible?
Yes, very much. Mahendra bhai.
Yeah, welcome friends,
Yes,
and thanks Heathrow Drugs, Dr. Prashant, Dr. Samruddhi, and Dr. Murli, and friends who have joined in, and some will join as the lunch gets over. Dr. Murli has been a friend for quite some time, very humble person. And just one thing I would like to say about Dr. Mahajan is that he is interested in genetics, has been doing genetic work and for quite some time. Now, in today's last few years, the genetic era and genetic diagnosis has come up. But Dr. Murli has been doing for, I don't know, maybe 15, 20 years. Right, Dr. Murli?
Yes, Mahendra bhai.
So Dr. Murli is the original genetist of Mumbai, I would say.
Thank you, Mahendra bhai.
Very humble person. So friends, we are going to talk about very common topic which we see in our day-to-day basis, and literally now is the season for the flu infections. So winter seasons are the season for flu, and most of us are aware of the various aspects of flu, but some few things which all of us may not be aware, we will discussing and will refresh those few things which we have already learned. Now, certain things, healthcare challenges in the monsoon, influenza, and the drug treatment, and certain guidelines for the empiric use of oseltamivir, and certain things on the vaccine part. Now, you can say it is one of the monsoon-related illnesses. Now, the influenza, basically, it belongs to the group of orthomyxovirus group. If you remember our microbiology days, there is orthomyxo and there is paramyxo. Now, this paramyxo group comes under the para-influenza group. So, the viruses basically are of three types, that is A, B, C, and sometimes D also, but we are mainly concerned with A and B. Now, the influenza C virus, which is there, it is basically a sporadic and doesn't cause much of an infection. So, it is mostly A and the B type, which we are more concerned. Now, A is responsible for most of the epidemics which have occurred till date, while B is restricted to some local spreads. Overview of the influenza in India, if you see, the cases are very high. In our OPD season nowadays, this thing, it's full of cold coughs and this thing. The presentations are similar. And morbidity and mortality in India, we don't have a robust surveillance system. So we do not get the actual figure for the morbidity and mortality, but I am sure as all of us clinicians, the incidence which we see is quite high. Now, coming to the structure, as Dr. Prashant and we were discussing, such a beautiful looking virus if you see this thing, but it's like the coronavirus where it causes lot of damage and lot of problem to children. If you see the blue color which is present, the blue color and the red color, these are the proteins of the virus which are present on the surface, and these are the ones which give it the antigenic properties. The blue color ones are the neuraminidase, the hemagglutinin, and the red ones are the neuraminidase. So if you recollect, when we say H1N1, the H refers to the blue color ones, that is hemagglutinin, and the N refers to the neuraminidase. And the coil structure which are present inside is the ribonucleoprotein. Now the epidemiology, as we told, it's worldwide. This thing spread across all the countries, and particularly in countries with a cold climate, the infections are very severe, such as US and the European countries. It can cause mild to severe illness. As we have already discussed, A, B, C, and sometimes people mention D also. And A and B are the ones which causes lot of endemics, and A is the one which cause epidemics. A causes frequent epidemics due to the minor antigenic variation and periodic epidemics due to the antigenic variation. Now, as the line suggests, there is a certain term called as antigenic drift and antigenic shift. When we say antigenic drift, that means the minor changes in the antigens of the virus. As we know, the flu viruses keep on changing and they have a lot of mutations, and every year it keeps on changing. So there is a minor change in the strain we call as antigenic drift, and it is not of very much significance. That doesn't cause much of morbidity or mortality. But when there is an antigenic shift, that is, there is a major change resulting in the formation of a new subtype. That is called as the antigenic shift. And this antigenic shift with the formation of a new subtype can cause epidemics and many times pandemics also. Now, as we saw in the previous slide, the blue color ones and the red color ones proteins, that is H and Na, they are, H is almost 18 types across all human and non-human hosts, and the blue is 11 types. So with permutation and combination of those types, we get new strains. For example, when we say H1N1, means the one type of H and the N1 type. And when we say H5, the fifth type of H5 and N1. So you can imagine with 18 types of H and 11 types of Na, so many combinations are possible. But fortunately, many are in the non-human, so we are spared. The transmission of the flu virus, as we know, well, mostly it's a droplet infection, and many times aerosol and fomites. Fomites are also an important aspect. So if you touch anything, well, be sure to do hand hygiene measures as we did during the corona. But after corona, we have left, we forgot the mask also. So this is a comparison of the various signs and symptoms between COVID, SARI, H1, and ILA. That is influenza-like illnesses and the severe acute respiratory infections. The only thing you have to see, the red highlights which is there, is breathlessness in H1 and SARI and COVID-19. And as you all know, loss of smell, loss of taste in cases of COVID-19. Now, we should remember there is one concept of spreading of the flu virus, the concept called as reassortment and the concept called as adaptation. Now, what is this reassortment? These terms are important to know the spreadability, whether it is endemic, whether it is epidemic or local spread. The reassortment means two, three viruses infect the host at the same time. So that is a reassortment. While as the adaptation is when a virus from a non-human host, for example, avian or swine, those infect humans along with the human type. So this adaptation phenomena is very important and it causes severe disease. For example, this avian flu, it is H5N1. So from a non-human host to the humans. We had a lot of pandemics, about 4 pandemics in the last 1 century. And the avian flu was around in 1997. And it is H5N1. And the other variation we had about 10 years back, and it is H7N9. One thing we should remember is that the infectivity in this chart, it is mentioned breathlessness in H1N1. Now, as we all know, people, adults, and children who are at high risk are the ones, particularly lower the age, more the chances of infections and more the severity, in particular children less than 2 years of age. And the other ones who are at high risk are with underlying chronic conditions, particularly anything systemic, starting from head to toe, neurological conditions, cerebral palsy, lung conditions, cardiac congenital diseases, any hematological conditions. Those are undergoing malignancy treatment. And also we should remember those at risk are pregnant or adolescents who are overweight with BMI more than 40. These are the people who are at high risk, and other metabolic conditions such as diabetes and this. The important thing is that in a study it was found out that about 40 to 45% deaths were in children who had no underlying condition, were totally normal. So we should not be complacent because of this particular figure. Almost 40 to 50% deaths. Now the complications, as we know, flu can cause complications from head to toe virtually anywhere. It can be a severe respiratory type of disease. But the most important complications are in the respiratory tract. Now, it also infects the middle ear. So, it causes about 25% of cases, they land up with acute otitis media. So, we should remember flu as a cause of acute otitis media also. And the respiratory tract, the mechanism is it infects the ciliated columnar epithelium. And because of this, the motility is affected, the mucus secretion is also suppressed, and the epithelial damage is done to the respiratory epithelium. And children are, as a result, more prone for secondary bacterial infections, which can be strepto or staph. It can cause ARDS, severe pneumonias, respiratory failures, and important is that it can cause encephalitis and renal and other sepsis complications also. And these are particularly more common in avian flu, that is H5N1 and H7N9. Now, coming to the clinical part, as we know, cough, cold, coryza. The difference is that it causes lot of headache and body ache as compared to the other respiratory infections, upper respiratory infections. So severe headache, body ache, just like the presentation like dengue. And it may land up sometimes if it is severe in myoglobin urea also. The other one is the diarrhea is an important clinical manifestation in H1N1. And as we said, in the immunocompromised host, due to any reason, the severity and the spreadability is very high. Now coming to the lab investigations, well, the blood report CBC is not very helpful. The only thing is that there are two types of tests which are available is the rapid diagnostic test and the other is the viral culture, the immunofluorescence and the RT-PCR. Now, in our OPDs, many times because of the cost factor, we ask for the rapid test which detects A and B, but it is not very specific. So the ideal test in our setting is the RT-PCR test. Now the rapid diagnostic tests which are there, which has about a sensitivity about only 40 to 50%, but the specificity is 95%. So basically, there is a chance of high false negativity with the rapid test. So the RT-PCR is the test which all of us should advise. Now the differential diagnosis, as you know, are the other viral infections, and this thing will not go much into it. Now, coming to the management of flu, the general measures, as you all know, the bed rest, fluid hydration, antipyretics. Now coming to the drug part, which is there. Three type of drug classes which are there. The one is the neuroamidase inhibitors, the amantadines, and two other groups are there. The amantadines, as we know, this is a quite old. We must have studied in our undergraduate days also. But a lot of this amantadine and rimantadine group has undergone resistance. So for practical purposes, this group is out. And the neuramidase inhibitors is present. And they have certain drugs such as oseltamivir, zanamivir, and boraxalavir. So these three drugs are important. Now the mechanism of action of oseltamivir, the diagram as we see, as we had seen earlier, the certain spike proteins are the blue ones are the heme agglutinin and the red ones are the neuramidase. And they go and attach to the cell, and there are the sialic acid receptors are there. And through that, it enters into the cell and undergoes viral replication. And once it undergoes viral replication and there is bursting of the cell and the release of virons which infect the neighboring cells, and there is multiplication. Now the neuraminidase which is there, this is important for the release of the virus. So broadly, we should remember two things. The heme agglutinin antigen which is there, it is useful for attachment to the cell, and the neuraminidase is important for the release from the infected cell. As we see the lower diagram, the mechanism of action of neuraminidase inhibitor, in this case oseltamivir, it helps in breaking the bond of attachment. So as a result of which the virus replication which is there inside it is not released from the cell, and as a result of it doesn't infect the other areas. The zanamivir group which is there, it blocks the production inside. Now something about oseltamivir. It was the first oral neuraminidase inhibitor, and it is approved more than 100 countries. Now, just two-line history regarding our searching for this oseltamivir history. Now I found out that all Chinese thing is not bad. This thing, in fact, it was founded in China from a Chinese NEC herb or Chinese star plant, and in our Indian houses, I think we call as Surya Full, which we use as herbs. So a certain citric acid is extracted from this herb, and oseltamivir is made. And the original plant and the original area for this plant is southern China, which is the conflict zone nowadays. But some good things have emerged from there. And later on in 1999 and later, now recombinant technology with E. coli and the other things. So that has come, and so it has been produced from recombinant technology and not from the herb now. Oseltamivir, it is 90% of it is excreted, and it is a prodrug form. It is converted into oseltamivir carboxylate, and then it becomes an active form and first pass metabolism in the liver. Now, as the drug dosages, as we all know, you must be well aware, in adults, it is 75 BD, and depending upon the weight, 15 milligram, various groups, 15 to 23, 23 to 40, and more than 40. So it is 60 milligram, 90, 20. 16, 90, 20. Very easy to remember, particularly those who are having nightlife. So 60, 90, 120, and 150. Now the prophylaxis is half the dose, that is 30 mg OD, 45 mg OD, 60 mg OD, and 75 in those who are above 40. Now, the recommended duration for the post-exposure prophylaxis is 10 days, and the recommended duration for community outbreak is up to 6 weeks. Now, For the treatment purposes, it's usually 5 days of treatment is there. But in severe cases, we can go up to 10 days also. Now, regarding the treatment, basically in admitted patients and those who are proved, the chart as you see, 1 ml is equal to 12 milligrams. So 5 ml is 60 milligram. In children, particularly less than 1 year of age, that is the infant age group, it is 3 milligram twice daily. Now, below 9 months of age, the prophylaxis part, because of adequate studies and the chances of side effects, prophylaxis below 9 months of age has not been approved yet. But for purpose of treatment, CDC and the American Academy, it proposes the treatment about 2 weeks of age. That is, a 15-day-old also can be treated with oseltamivir. The dose, as you said, is 3 milligram per kg. Now, there is a special section of preterm babies where the dose requirement is less. You have to give from 1 to 1.5 milligram per kg. So this is the treatment part. Regarding on the OPD basis, in the OPD basis, you have to remember that treatment always has to be done in a person particularly immunocompromised and all the risk factors which were already mentioned. So in those group, treatment has to be started without waiting for the reports. So if clinically matching, immunocompromised, or for that matter, even if a normal healthy child with clinical matching, the recommendation is that treatment should be started within 48 hours. Within 48 hours, the fundamental is basically once, as we had discussed, it goes into the respiratory epithelial and ciliated cell columnar epithelium is destroyed. This process takes from 1 day to 3 days. So in 72 hours, there is severe multiplication. So we have to catch this particular period. So ideally, within 48 hours, the treatment should be started. But many times, due to practical reasons, patients don't come to us within 40 hours. So as and when, even 4th day, 5th day, 6th day, if the patient comes and it is suspected or proven on reports, treatment should be started. Side effects are no major side effects of oseltamivir, but some things in very rare cases we have to remember that rash, Steven-Johnson syndrome, or toxic epidermal necrolysis may occur. So that is there. Now regarding the complications, one thing just like to mention of the disease itself, CNS complications, Guillain-Barré is a possibility. So Guillain-Barré is a possibility due to the infection, as well as it is a very rare possibility due to the vaccine also. Okay, now Dr. Murli will take over with few case presentations.
Thank you, Mahendra Bhai. Can you hear me now?
Yeah.
Yeah, thank you, Mahendra Bhai, for a very, very, very informative and a detailed presentation about H1N1. And Mahendra Bhai has covered almost everything. One thing also I wanted to inform the group that Dr. Mahendra Patel accumulates around 400 to 500 credit points in 5 years. That is his enthusiasm for learning. So maybe he attends more than 100, 150 conferences in a year, and he has a thorough knowledge about all the subject, which you can see today that when he was talking exactly from microbiological point of view, the pharmacological point of view, and clinical, he has covered all the aspect. So I'm just going to revise and share our experiences. What he was talking, absolutely correct. Can we have the first slide, please? So basically, what Dr. Mahendra Patel was telling is very, very important, that in our clinical practice, we have seen that the patients don't come to us in 48 hours. That is a main challenge. And as he rightly said, the viral replication by neuroamidase inhibitor, it will be only effective if the drugs are initiated in first 48 hours only. So what happens in most of these conditions, they would come to us after at least 4 to 5 days when they first go to their family physician, take routine medicines, and then when they doesn't get better, then they start with some antibiotic and some blood tests are done like CBC, CRP, and all that thing, and then they come to us. So by then, what I have realized, and as Dr. Mahendra will also appreciate, yeah, hello, yeah,
Yeah.
that we have lost the very crucial time of initiation of therapy. But however, even that case also, what we have seen is oseltamivir has given excellent results despite being delayed. So I'll share one child, 13-month-old child presented to me in OPD with complaints of cough, cold, and persistent fever for 5 days. 5 days, first he has gone to general practitioner, taken treatment, then he came to us, and the fever is not coming down, very high grade persistent. He has received antipyretics. Cough and breathlessness also started coming in. That is, he was getting into lower respiratory infection, and the child was very sick on consultation. There was no history of any cardiac disease. Next one. On examination, the child was very toxic. Like he was looking like classical viral infection, very toxic, as Dr. Mahendra suggested, that gastrointestinal infection and toxemia. This is very, very crucial in H1N1. See, normal viral infection, the child is not so toxic. They are usually very happy to go lucky. They're playing in between. But with H1N1, we have realized that they are little toxic. They have cold, cough, fever, and they have extreme body ache. Though this was child was looking at that, and he had crepitations and wheezes on examination, and X-ray as normally suggested of a bilateral diffuse haziness. So there is something haziness in these lungs. Wheezing is present, so the diagnosis is certain. It is lower respiratory infection with wheezy bronchitis. Next, please. The child was admitted. On admission, another set of antibiotics were changed. So what had happened? First, he went to general practitioner, started on azithromycin. Then he came to one pediatrician, which was started on augmentin. When he was admitted, he was started on ceftriaxone. So we have seen that in just 5 to 6 days, we have changed antibiotics 3 times. Oh, this is a red flag. So this is very important thing to remember, that most of this viral infection like H1N1, when we try to change antibiotic 2 to 3 times, we should better change our diagnosis. So we know that it is viral. So instead of viral infection, if you're giving 3 set of antibiotics, why not to give a proper antiviral medicine? Next, please. Yeah, this was air trapping, perihilar, streaking, everything was present. Next, please. Yes. Next, please. Yes. So this child was then started on oseltamivir, and child improved dramatically after starting of the medication. He was weaned off even antibiotic. Antibiotics were also not required. So the small take-home message from my first case was that many times we don't get such patients in our OPD in first 48 hours. Still, whenever we get this patient, if they have been started with one set of antibiotics by family physician, a second set of antibiotics by another pediatrician, it is remember that if we change antibiotics 2 to 3 times and a proper antibiotic doses, proper anti-inflammatory doses, if the child is sick, has diarrhea, body ache, lower respiratory infection, kindly consider it as a possible H1N1. And as Dr. Mahendra said rightly, in such cases, diagnostic tests are very costly. So the parents are not so keen to do the test because see already they have shifted to two doctors set of doctors already paid consulting there also. So moment they land up with us, they are very reluctant to do any test now. They want result more than the test. They have already done CBC, CRP, typhoid, malaria, dengue, all the basic test. So the throat swab will be again a very difficult situation in this case. So better to start on oseltamivir in these cases. And the child improved very, very dramatically after starting this condition. So basically the same thing was Dr. Mahendra was telling that a respiratory infection limited to upper respiratory tract and lower respiratory tract. Upper respiratory tract infection is laryngitis, rhinitis, adenoid, tonsil infection. And lower will be bronchitis, bronchopneumonia, pneumonia, haziness, and diffuse infection. Next, please. Yeah. Yes. So this is a diagram which shows how commonly we see bronchiolitis in our clinical practice. We know that bronchiolitis is caused by respiratory syncytial virus. A classical bronchiolitis will have tachypnea, no wheezing. But sometimes we get H1N1 and other viruses which is causing bronchial involvement and slight tachypnea. So in these cases, a differential diagnosis of H1N1 should be always at the back of the mind, and timely intervention with oseltamivir is very important and need of the hour. Next, please. Yes. After admission, the child was put on IV fluid, ceftriaxone, but however, nothing helped him. And moment the child was started on oseltamivir, within 3 to 4 doses, the child started becoming afebrile. The rhinorrhea decreased, the coughing decreased, the breathlessness decreased, and child became active, and he was suitable for discharge. Next one. Yes, this is another thing we know that how vaccines are changing the dynamics of H1N1 in our clinical practice. As Dr. Mahendra will appreciate that previously we never used to vaccinate children for H1N1 or flu vaccine. But with COVID pandemic and before that also some cases were reported, and now the timely intervention by use of this vaccine has given us excellent result. And nowadays we don't get to see those critical H1N1 cases or severe kind of infection, and they are milder in nature and they are doing very well. And as Dr. Mahendra has said, oseltamivir is a neuroaminidase inhibitor, and as he rightly said, H1H hemagglutinin will help in attachment of virus to the cell, and neuroaminidase will help in release of virus from the cell. So neuroaminidase inhibitor will kill the virus, block the virus and prevent the release of the virus from the cell. Next one. Next one. Yeah, this dose has been already nicely summarized by Mahendra Bhai. 60, 90, 120. Very, very nicely mentioned by him. Next one. So that's why I think Mahendra Bhai has done a lot of good job today, almost covered the entire presentation. Another interesting case I wanted to share, like we know that first is a group below 5 years of age. We always see children with wheezy bronchitis, bilateral hazy pneumonia, a very high fever, respiratory distress, and the classical symptoms of viral or H1N1 or RSV. There is one child who came to us with 7-year-old child who presented to us with chronic cough of more than 15-20 days. And the cough was so bad that he would never be able to sleep in the night. Again, the bottom line is that he was started on basic antibiotic erythromycin, azithromycin, augmentin, shifted to clarithromycin, and various set of antibiotics, humidifier, nebulizer, and whatnot. X-ray was normal, IG was normal. There was no allergic evidence in the past. The parents say that the child has no history of any allergy, asthma. There is also no history of asthma in the family member, but the cough continued and the child was referred to as only bus cough. Next, please. And we know that there are three kind of cough in the children. One is whooping cough, croup, and RSV. And at this age, RSV infections are less, laryngotracheobronchitis is less. But yes, whooping cough. Whooping cough could be common at this age because that is an incidence of whooping cough. Child has been vaccinated by the pertussis properly and already given erythromycin, azithromycin, everything was covered. Next, please. Next, please. So what was remaining was a throat swab or nasal swab. We thought, no, the child has terrible infection, again viral, not subsiding for 15 to 20 days. No eosinophilia, IG markers are normal. So can we do something to prove the diagnosis? Maybe it a culture or maybe a viral assay. So we thought of doing a throat swab and nasal swab in this child and also send bacterial culture also. However, the tonsils were normal, throat was normal. So what I did first, let us do H1N1 screening test or diagnostic test firstly in these cases. And as he rightly said, the PCR test is the best for diagnosis because no, PCR will definitely pick up the entire viral genome and it will help the differentiation of the virus. And surprisingly, this child was H1N1 positive. Next one. It's very, very surprising that, a child of 6 to 7 years old, chronic cough, stable in between, initially febrile, again becoming non-febrile, wheezing, upper respiratory infection, lower respiratory infection, whatever, both conditions. But the cough was not going only. And again, he was started on oseltamivir. And within 3 to 4 days, the cough decreased dramatically. Child was weaned of bronchodilator, nebulizers decreased, and now it is almost like 3 to 4 months since this episode. The child is doing perfectly normal. No history of any allergic episodes. There is no bronchitis and bronchiolitis. Next one. Yeah. So basically, what Dr. Mahendra has started with a beautiful session on explanation of H1N1. As a clinician, all of us we agree that many times we get to see these cases of H1N1 in two, three formats. One is acute respiratory infections, like lower respiratory infection, acute systemic infection, bronchiolitis, diffuse pneumonia, chronic cough. This is very new thing. And there could be anything which Dr. Mahendra wants to share, some presentation which I think I have missed and which you have seen sometimes, like cardiac involvement or anything else. Dr. Mahendra bhai, anything else you have seen for H1N1 apart from this?
Mostly, of course, respiratory, but one CNS, one or two cases I had
Yes,
seen.
yes,
It
yes.
was few years back, not now.
Correct, correct.
But after recent vaccination and this thing, those incidents have gone down. But
Yes,
few
that
years
is
back,
very
the
important.
CNS with proven RT-PCR proven positive.
Good, good. Of course, vaccination has made a lot of impact. The herd immunity has gone up, and during COVID times, almost most of the children have vaccinated, and few of them are still continue the vaccination annually, and that has given excellent result and prevention and decreased, I think, the severity and morbidity and mortality because of H1N1.
One thing about going through the history part of oseltamivir, I found out that it was originally manufactured by Gilead Pharma,
Oh,
which were the ones to make the remdesivir blockbuster drug.
oh my God.
So they are the ones who originally manufactured this thing.
My God.
So they had these two blockbuster drugs, COVID and this thing.
Yes, yes. Oh,
Very interesting how the microbiological epidemiology is
Should we
changing.
talk about vaccines or leave it?
And
What do we do?
no, I mean, it's okay, not needed.
Okay, okay.
But sir, it's very interesting how the epidemiology is changing. Once upon a time, it was only bacterial with hardly any, I mean, there were no drugs also or no diagnostic measures also. Principally, it was bacterial. Now it is changing to bacterial and viral. I
Hmm.
mean,
yes.
yes, the epidemiology is changing. And once upon a time, I remember that people were largely talking about bacterial infections. Of course, we did not have drugs and diagnostic methods, but that was it. It was very interesting how the disease pattern is changing.
Yes, yes. I think now the viral infections are becoming more difficult to
Correct, sir.
manage
Correct,
than
correct,
bacteria. See,
correct.
bacteria for we have at least antibiotic. For viral, there is
Absolutely,
nothing. There is
absolutely.
nothing. For 10,
Abs-
10 days, if the child is coughing, sneezing, and getting discomfortable,
Yes,
or the child respiratory distress, fever not coming down, so there are hardly any medication antiviral which are again safe
correct.
and efficacious. Both thing has to be there. Like
And how common is those atypical pneumonias these days, especially in children?
very much, very common.
Yes, yes.
Because
Yeah, it's increasing day by day.
No?
day by day, lobar pneumonias we don't get to see nowadays because
Ah.
everybody is given PCV
Yeah,
vaccine
yeah,
in
yeah,
old
yeah,
age.
yeah, yeah, yeah.
So the pneumococcal incidence by
Correct, correct,
lobar
correct.
pneumonia is gone only.
Oh,
Out of
oh.
100 X-rays, you will get
Ah.
only one lobar pneumonia,
Typical,
but
yes.
90 will be this interstitial, haziness, bronchiolitis. So viral etiology is more common than bacterial.
Correct.
And
And that's what,
X-rays
yes.
is rare to get. If you get lobar pneumonia, immediately ask for CT scan.
Acha.
Rule out TB, rule out TB.
This is
Few
exactly
of
how.
our, I met a few of our colleagues from New Mumbai.
Oh,
They told there are quite a few cases, sort of mini epidemic in New Mumbai, sort of mycoplasma.
oh my God.
Oh,
Mycoplasma, that is what, and few were very bad and requiring intensive this thing.
my,
That is the few colleagues had
oh,
interacted. We didn't see much, but that is what they reported. There are a lot of cases of mycoplasma. This.
Suarez also seemed to adapt it. In my college days, I remember, I was in JJ, by the way, sir.
oh,
And
very
James,
Acha.
I say authority first mention. And then we were taught that these atypical bacteria are largely prevalent where sunshine is no good.
yes.
Yes, but today see how the pattern is changing. I mean, they
So much.
also adapted. Yeah.
Yes, yes, very much.
It was very interesting, sir. Thank you very much,
Thank you,
Dr.
thank you.
Mahendra,
And
Dr. Muralidhar.
any question answer from the participants?
Not as yet, we have not received. In case we receive, we'll come back to you.
You
But not
can
as yet. So
unmute
yes,
everybody and this thing. If anybody wants to ask,
there will be a different link. There will be, other they are supposed to put on the chat. But in case it comes
No,
to us,
there are
we
no
will.
questions as
There are,
such now,
yes.
up till now.
But in case it comes, we will roll it back to you.
Nice. Thank you.
the
Thank you.
the only thing, yeah, as a company, I just wanted to ask you.
Yes.
I mean, trial studies or literature, what is the amount of drug resistance to oseltamivir are you encountering?
Have we done
Or
some
any
studies? I don't think we've done it. Somebody, have we done any studies, epidemiology studies on
or any
resistance?
world studies, any world
No, sir.
No, we have
No.
not done anything, sir. That's it.
acha.
Anyway, thank you, both of you. It was
Thank
a
you,
lovely
thank you.
session.
Thank
A
you,
lovely
sir.
session. Thanks
Thank
all the
you.
audience who took time from their scheduled and attended this. And thank
Thank
you,
you.
marketing team, for organizing such a wonderful meeting. It was a really, interesting to know
Eye
a
opener
lot of
and very
things. Yes,
practical, very
yes,
practical.
yes, very practical. And thanks, field people, and thanks, IT team Hitro for conceptualizing this, for supporting this. Thank you.
Thanks a lot.
Yeah.
See you.
Thanks.
See you.
Thank you,
Thank
Murli.
you.
Yeah.
Thank you, sir.
Thank you,
We'll
Murli.
log out, sir. Thank you.
Bye. Thank you.
Thanks, sir.
Thank you, Hitro.
From Hitro, from Universe, will come back, sir.
Yes, thank you, sir.
Yeah. Maybe.